I think we have a good number of folks, so we can get started. Well, welcome all to the second April session of the Virtual Learning Collaborative, made possible in partnership with the CDC Division of Viral Hepatitis. My name is Zakia Grubbs, and I'm a manager on the hepatitis team. Today's topic is characteristics of hepatitis B mortality and considerations for health departments. Joining us today are our speakers, Eman Addish, Senior Viral Hepatitis Epidemiologist with the Division of Disease Control at the Philadelphia Department of Public Health, Kathleen Lee, Epidemiologist with the Epidemiology and Surveillance Branch within the Division of Viral Hepatitis at the Centers for Disease Control and Prevention, and Dr. Philip Spradling, Medical Officer, Epidemiology Research Team with the Epidemiology Surveillance Branch within the Division of Viral Hepatitis, also with CDC. And finally, we have our moderator, Danica Kuncio, Viral Hepatitis Program Manager, also with the Philadelphia Department of Public Health. The format for today's session is as follows. We will begin with presentations, followed by a Q&A and discussion facilitated by Danica. Feel free to use the chat to introduce yourselves and your jurisdiction for your questions. So now I will hand it over to Kathleen and Phil for their presentation.
Great, thank you. Good afternoon, everyone. Kathleen, are you driving? Who's handling?
Yes, yes, I am. Let me share my screen.
Thank you. Well, thank you all for the opportunity to present this afternoon. Our talk is going to be on regional differences in mortality rates and characteristics of decedents with hepatitis B listed as a cause of death, United States, 2000 through 2019. I was reflecting today a little bit, actually coming up with a title for this work was one of the more challenging things for us because the scope of it's pretty wide, as you will see. So we'll get on with it. Next slide. Thanks, Kathleen. So for just a little background, persons with chronic hepatitis B can develop chronic liver disease and suffer premature mortality as a result. But one other thing to keep in mind is that persons with acute fulminant hepatitis B can also experience premature mortality. And we'll touch on that a little bit later. Chronic B has been associated with elevated mortality rates from all causes. And looking at death rates over the last preceding 2 decades, at least according to US surveillance reports, the hepatitis B listed death rate has been pretty stable over the previous 2 decades. It went down slightly, but it remains about 3 times higher than the 2030 target for hepatitis B death rates. Among the decedents during this period of time, most were over age 55, most were non-Hispanic, Asian, Pacific Islander descent, and were male. And in the past, published hepatitis B mortality reports, at least in terms of US hepatitis B mortality, have lacked information on decedent place of birth, on comorbidities and underlying versus contributing causes of death, in addition to the fact that they generally look at the nation as a whole. So it's sort of a homogeneous picture of mortality. Next slide. So as a result of that, we posited that examining hepatitis B mortality from a subnational perspective could help us identify differences of importance in terms of mortality rates and decedent characteristics in the US. So our objectives were to analyze state-level hepatitis B listed death counts, rates, and characteristics of decedents, and to examine the distribution of sociodemographic characteristics, median age at death, and underlying cause of death among US born and non-US born decedents with hepatitis B listed deaths. And Kathleen will discuss the methods.
Yeah, hi everyone. So In an effort to show our process for how we conducted our analyses, I'm going to try to go through our methods carefully. And I can also share more specifics and instructions about our approach afterwards if I wasn't able to cover them in these slides. I also wanted to mention that though our analyses are specific for hepatitis B mortality, a modified version of this process could be followed for analyzing deaths associated with other viral hepatitis conditions. So we submitted a project proposal or project determination to CDC's National Center for Health Statistics, or NCHS. It's the CDC program that manages the national vital records data. And we had to submit a project determination because we wanted access to the restricted level multiple cause of death data, or I'll refer to as MCOD from this point forward. And we wanted to examine the study period from 2000 to 2019. So we needed the restricted use data, even though public use data are available, because the restricted use data includes data at the state and county level. So it can tell us, state and county decedent residents. And there's also information on state and country of birth, whereas the public use files after 2004 do not contain any subnational level data. So it's just at the national level data without geographic identifiers. So we analyzed the MCOD fields for each US resident decedent, in which cause of death conditions are translated into international classification of diseases 10th revision, or ICD-10 codes. We examined both the underlying and contributing causes of death. So briefly, the underlying cause of death is the one disease or injury that initiated the chain of morbid events leading directly to death, whereas contributing causes, in which there can be up to 19 in the MCOD data files, are comprised of the conditions which unfavorably influence the course of the morbid process and thus contributed to the fatal outcome. So we used all causes of death to err on the side of completeness, since we found that 70% of all hepatitis B deaths had hepatitis B listed as a contributing cause. We defined a hepatitis B listed death as a death for which at least one ICD-10 code indicative of acute or chronic hepatitis B, which could also include super or co-infection with hepatitis D or Delta, was listed as the underlying or contributing cause of death. And then among these deaths, we also searched for the presence of a listed infection with hepatitis D, hepatitis C, and HIV, as defined by these ICD-10 codes listed in this table. And then finally, because hepatitis B in the US, as you all know, has two different epidemiologies, all of our analyses are stratified by US birthplace status. So for each state and the District of Columbia for our statistical analyses, we calculated the number of hepatitis B listed deaths, the age-adjusted death rate according to the direct method, and I've included the references here at the bottom for your reference. The median age at death, since we know people living with hepatitis, chronic hepatitis, can die prematurely. And then also the distribution of US-born versus non-US born status, and the distribution of co-infection with hepatitis C, HIV, and hepatitis Delta as they're reported on the death certificate. We also examined at the national level the distribution of social demographic characteristics and underlying cause of death categories. These categories we borrowed from a study from another colleague, Dr. Dee Bixler, for her another analyses looking at the checks data with chronic hepatitis B mortality. And we stratified these analyses by US birthplace status. So here are the results. All right, so this is an area proportional Venn diagram showing the distribution of the 269,504 deaths, where hepatitis B, hepatitis C, HIV, and hepatitis D, as in Delta, were listed as a cause of death during 2010, to 2019. So focusing on the more recent 10-year time period. And as you can see, this diagram illustrates the syndemic interactions between these infections. And then when we're looking specifically at the hepatitis B listed death, we found that there were 17,483 deaths for which hepatitis B was listed as a cause of death, or 6.5% of the total. And then among these hepatitis B deaths, we found that approximately 1/4, or about 4,300 deaths, were listed with hepatitis C. 5.5%, or 961 deaths, were listed with HIV. 1.7%, or 295 deaths, were listed both with hepatitis C and HIV. And then we found that there were only 6 deaths to which hepatitis Delta were listed as a cause of death, and sort of underscoring the importance of what we know, that there's under testing for hepatitis Delta in the United States. Okay, so this map shows state-specific age-adjusted hepatitis B listed death rates during 2010 to 2019, where the darkest shaded states represent those with the highest death rates for hepatitis B. So the overall hepatitis B listed death rate, or national rate, was 0.47 deaths per 100,000 population. 12 states had a death rate that significantly exceeded the national hepatitis B listed death rate, which were primarily concentrated along the coastal and Appalachian regions. So these are, in descending order, the District of Columbia with the highest rate of 1.78 deaths per 100,000 population, followed by Hawaii, Oklahoma, California, Tennessee, West Virginia, Mississippi, Oregon, Washington, Louisiana, Kentucky, and New York. The overall median age at hepatitis B listed death was 60 years, with an interquartile range of 53 to 69 years. Significantly younger median age at death than the national distribution, as indicated in red on the map, occurred in Kentucky, West Virginia, Tennessee, Ohio, and Mississippi, so primarily Appalachian states, with a median age range of 54 to 59 years. And finally, California, which had a median age at death of 63 years, was the only state that had a significantly older median age than the national distribution. So in the interest of not overwhelming you all with large tables, we are presenting a shortened version for all tables, just focusing only on the major findings. But all of the result tables can be found in their entirety in our publication from JAMA Network Open. So this table compares the distribution of social demographic characteristics and listed co-infection among US-born and non-US-born decedents who had hepatitis B listed as a cause of death. So as you can see, when compared to non-US-born decedents, US-born decedents were more frequently aged 45 to 64 years, born during 1945 to 1965, non-Hispanic white, non-Hispanic Black, and had hepatitis C, HIV, or hepatitis D co-listed at death. And though not shown here on the table, I did also want to mention for non-US born decedents, they were more frequently aged 65 years and older, and of non-Hispanic, Asian, or Pacific Islander descent, or Hispanic descent. So this table summarizes the state distribution of US born and non-US born decedents who had hepatitis B listed as a cause of death. 7 states, as shown in the first row, had a significantly higher proportion of non-US born decedents than the national distribution of 37%. And these were listed in descending order. And so starting with a high for California of about 65%, followed by Minnesota, Hawaii, New York, Massachusetts, Washington, and New Jersey with 47% non-US born. Compared to this, there were 22 states that had a significantly higher proportion of US born decedents than the national distribution of 63%. And so that's shown in the fourth row on this table. And you can see the 22 states listed here, which range from a high of 95% US born in Mississippi to a low of 71% in Florida. So this slide describes our comparison of the distribution of underlying causes of death for US born and non-US born decedents who had hepatitis B listed as a cause of death. So first, we found that hepatitis B was listed as the underlying cause of death for about 30% of all hepatitis B listed deaths. And when we examined this by US birthplace status, this distribution was not significantly different. So they were both about 30% each for each group. Next, when we examined decedents for which hepatitis B was listed as a contributing cause of death, we found that liver cancer was listed as the underlying cause of death for 54% of non-US born decedents, compared with 21% or 1 in 5 of US born decedents, as shown to the right in this table. And conversely, we found several conditions that were significantly more frequently listed in the underlying cause of death among US born compared to non-US born decedents. And these were hepatitis C, other viral hepatitis, which was primarily hepatitis A, alcohol and non-alcohol liver-related conditions, HIV infection, circulatory and respiratory conditions, injuries or trauma, mental or behavioral health disorders, and other. With regards to the median age at death, US-born decedents, when compared to non-US-born decedents, had a significantly younger median age when hepatitis B, hepatitis C, non-alcoholic liver disease, circulatory conditions, respiratory conditions, diabetes, and injuries or trauma were listed as the underlying cause of death. And so we also compared our hepatitis B decedents to decedents who did not have hepatitis B listed as a cause of death. And in doing that, we found that, first of all, overall, and for most underlying cause of death categories, both US born and non-US born decedents who had hepatitis B listed had a significantly younger median age at death when compared to decedents who did not have hepatitis B listed at death. And then next, we found that the 3 most frequently listed underlying causes of death among both US born and non-US born decedents with hepatitis B listed were hepatitis B, liver cancer, and non-liver cancers, noting that nearly 1/2 of non-US born decedents had any type of cancer listed. And then contrast that with decedents who did not have hepatitis B listed, we found that the most frequently listed underlying causes of death were circulatory conditions and non-liver cancers. Okay, so for this map, we assessed death rate changes from the first 10-year time interval of 2000 to 2009 to the second 10-year time interval of 2010 to 2019, and found that the national hepatitis B listed death rate declined by 19% from 0.58 to 0.47 deaths per 100,000 population. And this was significant. And also we found a significant decline in death rate also among 14 states, as indicated by the red state abbreviations. However, we did find a significant increase in death rate, and that was observed specifically for West Virginia and Kentucky, and that's indicated in yellow. All right, so I'm going to turn it back over to Dr. Spradling to talk about our study limitations and conclusions.
Thank you, Kathleen. Well, to get the limitations out of the way first. Thank you. We couldn't directly compare age-adjusted death rates for US versus non-US born persons because we didn't have population denominators. So that was sort of our primary limitation. The other thing, and there's a lot that could be said about this, is that there is definitely variability in provider reporting of conditions leading to death. We know that there's an underestimation of true hepatitis B mortality burden due to underdiagnosis of hepatitis B, the study that Kathleen alluded to earlier by D. Bixler, I believe showed that about 20% of all cohort B patients who died had hepatitis B listed on their death certificate. But the hepatitis B patients with known liver disease, only 40% of those were listed. So we know it's underreported, under-ascertained. The other thing to mention is that American Indian and Alaska Native persons are often misclassified as other race groups on their death certificate, which results in underreporting of conditions. So just to go through sort of the summary, we've kind of put the main findings in the left column and then sort of our interpretation and commentary on the right. But the first, as Kathleen showed, hepatitis B listed death rates were significantly higher in 12 coastal and Appalachian states, which showed that this approach, looking at state differences, provided baseline estimates of state and regional level hepatitis B deaths, which can be used to identify high mortality burden areas and inform state public health and elimination efforts. We saw significant increases in hepatitis B listed death rate in West Virginia and Kentucky, but these states and other states in the Ohio River Valley have also experienced high death rates from all causes and pronounced declines in life expectancy, in large part from opioid deaths and other so-called deaths of despair. The other thing, the next bullet, which may seem a little out of place, is that this supports universal B vaccination and harm reduction efforts. I should mention that West Virginia and Kentucky are among the states, I believe, with the highest acute hepatitis B rate. So there is definitely ongoing transmission, hepatitis B transmission in these areas, a lot of it driven probably by injection drug use. The other thing to remember is that hepatitis B can be transmitted sexually. So people who acquire hepatitis B through injection drug use can conceivably transmit it to persons who don't inject. The next finding, US-born decedents constituted 63% of all hepatitis B listed deaths, and this was contrary to published NHANES prevalence data, which indicates that about 70% of prevalent cases in the United States are non-US born. So this was basically the flip of that. We found significantly younger median age at death in the Appalachian states mentioned. Most decedents were overwhelmingly US born, and significantly older median age at death in California decedents who were predominantly non-US born. And hepatitis B listed decedents had a significantly younger median age at death when compared to non-hepatitis B listed decedents, and that applied to US and non-US born persons with hepatitis B. So in the context of hepatitis B, despite US born persons having presumably a shorter duration of chronic infection, they nonetheless had a significantly younger median age at death. Thanks. Liver-related conditions were the most frequently listed underlying cause of death among both US-born and non-US-born hepatitis B listed decedents. Liver cancer was the predominant underlying cause of death among non-US-born decedents, and when you factor in non-liver malignancies, 50% of non-US-born persons with hepatitis B died of some kind of malignancy. Compared to non-US-born decedents, US-born decedents more frequently had non-hepatic conditions listed as underlying cause of death. So we know that US-born persons with hepatitis B may more frequently require diagnosis and management of viral co-infections, respiratory and cardiovascular conditions, non-viral liver disease, and addiction-related sequelae. And this, another bullet that could be applied everywhere. These findings support universal adult hepatitis B screening and vaccination. And it's a reminder that all persons with chronic B, irrespective of how long they've been infected, certainly need diagnosis and ongoing clinical management.
Phil, I think you're going to cover this slide, right?
Oh, okay. So anyway, we're going to move to very quickly a follow-up study that we're going to be doing. And just to sort of bring up some of the questions that we're going to pursue, we are interested in looking at whether there are differences in social vulnerability indicators among hepatitis B decedents according to US versus non-US birthplace and in relation to state and county location. We also want to explore whether there's a relationship between social vulnerability and hepatitis B mortality rates, as well as whether there's a relationship with early hepatitis B related mortality. And we also want to know whether identification of geolocation specific social vulnerabilities among hepatitis B decedents, can this information inform, focus, and improve public health interventions for persons living with chronic hepatitis B?
All right, thank you, Phil. So to answer these follow-up questions, we are borrowing and modifying the approach from numerous studies that have already been published for COVID-19, and also for a growing number of other health conditions for which disparities among underserved populations have been documented. So we are exploring the use of CDC's ATSDR, Social Vulnerability Index data, which is a data source that provides a standardized metric that incorporates census tract and county level data to identify and compare communities that are deemed vulnerable according to specific social and environmental determinants. The SVI data are based on rankings of estimates from the US Census and also the American Community Survey using 15 domains that are grouped into these 4 themes as shown in this graphic. There are national rankings as well as state level rankings. And within each of those geographic settings, there are separate data files available on the website containing SVI rankings at the county level and more granularly at the census tract level. So these data sets, they could be easily merged with your surveillance data, or in the absence of more complete surveillance data, you can use your mortality data if you have geographic identifiers in both data sources. So our plan is to merge the SVI data with the US MCOD data by decedent county of residence to answer these follow-up questions that Dr. Spradling just summarized. So I wanted to briefly mention our DCIPHER data integration project. This work is being led by our team lead, Dr. Nicola Thompson, and also Dr. Fozia Ajmal on our team as well. So DCIPHER is a web or cloud-based data platform that can be used for data integration, data management, and analyses. Our division is currently working to bring viral hepatitis surveillance data from NNDSS and mortality data from CDC Wonder into DCIPHER. We've started a pilot project with about 6 jurisdictions, and it's kicking off this month, and we'll start onboarding jurisdictions for the remainder of the year with the goal of middle of next year to have complete onboarding for all jurisdictions. So in addition to those surveillance and mortality data sources I just mentioned, we're planning to incorporate SVI and other place-based social determinants of health data sets into DCIPHER so that jurisdictions can view their surveillance and mortality data in the context of social determinants of health data sources. And then finally, many of you attended our recent 2103 national call, in which you heard our Hawaii colleagues, Thaddeus Pham, and his co-authors provide a really excellent presentation on their use of CDC Wonder mortality data to examine hepatitis B mortality trends in Hawaii. So our division, we also use CDC Wonder to produce tables and figures to characterize hepatitis mortality for the US in our annual surveillance reports. So I included some screenshots here so you can see the types of analyses and conclusions from these data from DVH and our Hawaii colleagues. Briefly, CDC Wonder Mortality is an online query tool in which the data source comes from US MCOD data. These data are aggregated, so they're not at the line level data. And you can perform easy state, national, or county level queries and output statistics, such as proportions, crude and age-adjusted death rates, as well as standard errors and confidence intervals for those rates. So just wanted to mention this as an option. And I'm sure Thaddeus, as well as myself, we can definitely talk to you more about the specifics of CDC Wonder if you're interested in exploring it further. All right, so briefly just wanted to mention and acknowledge the contributions of Dr. Xiaoman Yin, who's a co-author on our project and also a mathematical statistician. So I'll turn it over to Eman. Thank you.
Isabella or Zakia, do you guys have my slides?
We sure do.
Perfect. Awesome. Okay. Well, hello, everyone. My name is Eman Addish, and I'll be talking to you today about our sensitivity analysis on death certificates for hepatitis B and hepatitis C related mortality for Philadelphia. Next slide, please. Perfect. As we all are working towards viral hepatitis elimination, we have target goals set by the World Health Organization, which states a 65% reduction in global mortality due to hepatitis B and hepatitis C by 2030. And the CDC set a greater than or equal to 20% reduction in national mortality due to hepatitis B and C by 2025. To track this metric and quantify deaths due to viral hepatitis, jurisdictions will need access to death certificate data. Next slide, please. The goal of this analysis is to determine the utility of using death certificates as a data source for measuring a critical elimination goal and its progress. In this analysis, we measured the sensitivity of hepatitis B, hepatitis C, or viral hepatitis listed as a cause of death, underlying or contributing cause of death. We also identified deaths related to viral hepatitis, which we are using as a proxy. Next slide, please. The data sources we utilized were the electronic vitals death data of all Philadelphia residents from 2015 through October of 2021, and cases of hepatitis B and hepatitis C that were reported to the Philadelphia Department of Public Health's longitudinal viral hepatitis registry. We also reported past or present infections at death from 2015 through 2020. Next slide, please. Our methods for this analysis include matching death certificate data to our viral hepatitis registry on name and date of birth using SAS 9.4. Sensitivity was measured for having viral hepatitis as a cause of death, and we also looked at causes of death that were likely related to viral hepatitis, which included non-alcoholic liver disease and hepatocellular carcinoma, which we will be referring to as our proxy. We also created a new viral hepatitis death estimate for Philadelphia and assessed the association with various factors on the death certificate using chi-squared, Fisher exact, and t-test analysis where appropriate. In addition, a multivariable logistic regression was performed to account for significant covariate relationships. Next slide, please. Now for the results. We started with our viral hepatitis infections in our registry and decedents from the death certificates during the inclusion period. After the match, 18% of the cases in our registry had matched to the electronic death certificate data. Among all cases that matched, 14% had a cause of death or underlying or contributing cause of death listed as viral hepatitis or our proxy. Among the 1,458 cases, 31% had viral hepatitis listed as a cause of death or contributing or underlying cause of death, and 69% had the proxy listed. This resulted in a sensitivity of 31%. Next slide, please. Oh, I think we went backwards. Perfect. When it comes to building a mortality estimate, we saw that by looking just at the death certificate data alone, we had 944 deaths due to viral hepatitis. By matching to our viral hepatitis registry, we found an additional 1,006 deaths with viral hepatitis as a cause of death, which brought our total of viral hepatitis related mortality to 1,950. So by using the death certificate alone, we only accounted for 48% of deaths caused by viral hepatitis. And by excluding individuals who were not in our registry after the match, we accounted for 75% of the total deaths attributed to viral hepatitis. In addition, according to the literature, 65% of hepatocellular carcinoma is caused by viral hepatitis, so there is probably 593 additional individuals who may have a cause of death attributed to viral hepatitis. Next, I'll go through the demographics of the decedents based on the presence of viral hepatitis as a cause of death. In this slide and in my next, the blue bar represents viral hepatitis being listed as a cause of death, and the orange bar represents not having viral hepatitis listed as a cause of death, since these decedents had the proxy listed. We saw that the younger age group were more likely to have viral hepatitis listed as a cause of death versus the older age group, which was statistically significant. Next slide. When looking at factors on the death certificate, we saw that education level and marriage status were not statistically significant, but we did see that death certificates signed by a medical professional were more likely to not list viral hepatitis as a cause of death. Next slide. We built a multivariable logistic regression model to obtain adjusted odds ratios and 95% confidence intervals for variables that were significant in our univariate analysis. We found that having viral hepatitis listed as a cause of death was seen at a 2.34 increased odds among decedents aged 36 to 49 years old, and we saw a 1.29 increased odds among decedents aged 50 to 64 years old, and a 41% decreased odds among records that had a medical professional as the signee when holding all other variables constant. Some of the limitations that we face included not being able to calculate the positive predictive values, since decedents that were not in our viral hepatitis registry could not be used in this analysis. We also knew that not everyone with viral hepatitis is diagnosed and in our registry, and further analysis will be needed to validate the proxy of using non-alcoholic liver disease and hepatocellular carcinoma as a proxy. Next slide, please. In conclusion, in Philadelphia, death certificate data is an incomplete source for viral hepatitis-related mortality due to low sensitivity of hepatitis B and hepatitis C reporting. Jurisdictions should validate any data source used to assess metrics around deaths for hepatitis elimination activities. We should also explore updating standardized protocols for medical professionals to improve reporting of viral hepatitis in cases of liver-related death. And matching of viral hepatitis registries and the use of proxy for cause of death, such as liver cancer and liver disease, should be considered to better understand the mortality impacts for viral hepatitis. Thank you all, and I would like to also acknowledge my colleagues, Danica Kuncio and Kelly Gillespie. Thank you.
Thanks, Eman, Kathleen, and Phil. So now, after those two incredible presentations, I would like to open it up for questions from everybody on the call. We do have one in the chat from Rachel, and I encourage everybody else to either raise your hand or put them in the chat, and we can have a fruitful discussion based off of this incredible information. So in the chat, Rachel from California put that I think it's a two-parter, thinking about how there are different underlying or there's bimodal groupings of populations for hepatitis B. We see the foreign born individuals who may most likely had hepatitis B, or there was hepatitis B transmission perinatally or early in childhood, and then US born, it might be more likely, or at least in newer transmission related to drug use. So is that kind of the big takeaway from a lot of the conclusions, Kathleen and Phil, for your paper, that there are these underlying drivers of the different populations that we're seeing, probably making these differentiations between states, between US born and non-US born? And Rachel, I probably butchered your question. If you would like to be more articulate with it.
I think the question is, like, are we actually just describing different phenomenon that for the same disease, but like completely different epidemiologic profiles, basically?
Way more articulate. Thank you.
Yes, that is correct, Rachel. So, in our previous analyses, we've never been able to look at US birthplace status for decedents. In the mortality data for hepatitis B, we know it's a big issue, and at the national level, there's likely sampling bias and Haynes, where we can't look at, US born persons with chronic hep B adequately because of small sample sizes. So this analysis was to kind of help differentiate and tease out the two groups more fully.
And Rachel had a follow-up question with that, Kathleen, around looking at overdoses and them being a potential driver for skewing the deaths amongst people who inject or use drugs.
I mean, it sounded like US born people died younger, and I'm assuming that's probably because of overdose, but I don't know if that was a correct assumption.
Yeah, thank you for that question. And I'm pulling up the larger table, so it has more information. So under the injuries or trauma category, you can see that we did parse out like drug overdose, not specifically drug overdose, but it's combined with, alcohol poisoning, suicide, or homicide, just kind of sticking with the categories that Dr. D. Bixler had used versus injuries or trauma that did not include those conditions. And just kind of looking at like kind of total burden of the whole for US born and non-US born, those deaths did not contribute much. I think it's about 2.3% and 0.3%. So it didn't make a, in terms of a big dent into the total burden, but it could have contributed somewhat. And I think I have another slide in terms of looking at median age. I think, and this is probably a product of small cell counts, but there wasn't any significant differences between median age. But I do think that there's some interactions going on there that could be driving the median age down, as well as, we found that US born persons also had like a multitude of other hepatic and extrahepatic conditions at play. I'll also defer to Dr. Spradling because he has possibly some additional insights.
Thanks, Kathleen. I guess one other thing that I sort of touched on initially was whether some of these or how many of these could be acute hepatitis B, fulminant acute hepatitis B deaths, particularly in areas where there are older adults or adults who are unvaccinated and potentially have pre-existing liver disease from alcohol or non-alcoholic fatty liver disease, or have hep C co-infection or something, so that should such a person get acute hepatitis B, perhaps they're at greater risk of dying of acute hepatitis B. And that's one of the indications of, when we recommend hepatitis A and hepatitis B vaccine for persons with chronic liver disease, it's based on the idea that if such persons get acute on top of what they have, then it has bigger consequences. The trick with this is, and is when you go to the MCOD data and look at hepatitis B deaths, about 85% of them are classified as acute hepatitis B deaths. And we know that's not the case because a lot of those are also have HCC listed as a cause of death, so it's probably not acute. There's some of that going on. The other issue, I guess, in some of these states with the early age at death and rapid progression to severe disease is the potential for undetected delta hepatitis in some of these populations, particularly in Appalachia, where there's more IDU going on. There's certainly more interest in delta, and I think this could potentially be an explanation as to why people are dying younger there. So anyway, I'll be quiet at this point. Thank you.
No, thank you for expanding on that. And I think asking the, building off of that in talking about potential misclassification or lack of identification, clearly your study did a lot to build on previous estimates by including these underlying causes of death and these contributing causes of death. But looking at the work that Eman presented, how do you think that the potential lack of identification of hepatitis B on birth certificates death certificates amongst people who may be dying from a hepatitis B related cause or Hep B specifically, how do you think that might affect your estimates, or do you think that will affect the results of your study?
Yeah, I mean, I think that was one of our major limitations, and we spent at length talking about it in the limitations section. That is the biggest limiting factor with these analyses, is that we know that this just represents sort of like a baseline minimum estimate of burden of mortality. It doesn't represent the whole. And I think Eman also alluded in her conclusions about standardizing provider practices on reporting these conditions, especially when there's a proxy indicator such as liver cancer. I think also some of this may also improve with wider implementation of universal screening to which people would be diagnosed in a timelier manner, and the provider would be aware of it at the time of death.
I was going to say something else with respect to acute B. When we look at the surveillance data, and I think we did look at it for the past 7 or 8 years, and I believe it was less than 1% of reported B cases died. I think it was 0.6% over that period of time. So I don't think there's rampant death from fulminant acute hepatitis B, but I think it is definitely something that we need to be cognizant of. And it would certainly, from a surveillance standpoint, it's important to report on the case report form, even if the patient doesn't die. A zero report or non-death report is important, because I think we're missing a lot of data for that field. We assume we're catching the deaths, but it would be nice to have complete data.
Absolutely. I think, stepping back a little bit from the specifics of both analyses, can you either group or if anybody from the call wants to chime in, talk about the utility of this mortality data? It's very interesting to look across state lines and compare what might be happening, between Appalachia and the coastal communities. It's interesting, but what's the utility for the people on this call? What can jurisdictions do using this information, using these tools, looking at the breakdown of drivers of mortality within their jurisdiction to help achieve elimination?
Yeah, I guess I can start. At the minimum, it does provide, some sort of like baseline estimate of the burden of disease in a jurisdiction, but recognizing that it is underreported. So this is sort of like a minimum estimate. but it still could be useful in the absence of good prevalence data, or, jurisdictions who are still, improving their surveillance system. I think Hawaii demonstrated a good example where they're able to put out, some estimates of the mortality burden for, resource planning and policy decision making in their jurisdiction. I guess the other thing is our data, we found like decedent characteristics are pretty complete. So I think, race ethnicity, it was like greater than 90% completeness. Whereas, we know for surveillance data, it's often very resource intensive to get that information because it's not on the lab report, and you'd have to do follow-up to get it from the medical records. So at least with the deaths that we are capturing, we could characterize them with more complete data, but recognizing there's other limitations, like there could be misclassification, as Phil had mentioned, with race ethnicity groups. And then just finally, just recognizing that, these data sources, if you have, both like surveillance and mortality data, they should be looked at together to kind of get a fuller understanding of what's going on in your jurisdiction, given the nuances with both data sources, and also with their prevalence data. If you do have prevalence data, jurisdictions can match the death certificate data and pull out people who have died for their prevalence estimates.
Phil or Eman, did you have anything to add to that?
Yeah, it was just going to say, in some respects, these deaths represents a failure of sorts in terms of a continuum of care kind of picture to get to the point. Late diagnosis, referral to care, treatment. Obviously, people with expert care can still die of hepatitis B, but I think it's something to keep in mind.
Eman, did you have anything to add? If not, that's okay. I just wanted
I know that there's a question in the chat, but no, I definitely agree with what Phil and Kathleen said, and especially with what we found with individuals who were had a liver cancer as the cause of death, kind of just making sure that providers are screening for liver cancer, since that was a big thing for us.
We have a couple questions in the chat. So one, looking at specifically in Appalachia, was co-infection a driver of or a driver of the contributing of the increase of death rate in Appalachia, co-infection with B and C, or was it not part of that?
I thought it was part of it.
Yeah, I mean, if there's time, I can share my screen real quick. I think this is probably in the appendices. Okay. Can you see the slide?
Yes.
Yes.
Okay. Yeah, so you can see here the co-infection. This is a stacked percent bar chart. So the dark green represents states' level of co-infection among hepatitis B decedents, and this is in increasing order of co-infection or decreasing order of non-co-infection. So as you can see here, these are the states in which there's more co-infection, and there's West Virginia, Tennessee, Kentucky, Ohio, and here's the national as a reference point. So these are primarily catching the Appalachian states, whereas we see the jurisdictions in which we know there's more foreign-born populations, so Hawaii, California on the other end.
Thank you. And then there was another question about stratification of race ethnicity by country of origin. Were you guys able to do that as well?
Yeah, so here is that table. So by US versus non-US. So
see that? You see?
Can you see this okay, or okay? Yeah, so for US born, 67%, about 2/3 are non-Hispanic white, followed by non-Hispanic Black, and the predominant race ethnicity group for non-US born decedents was the API group. And it's pretty heavy on the API group. I hope I answered your questions.
I think you did. Thank you, Kathleen.
Okay.
And there was one additional question from Hillary, who I think this is a really great question. Either as a part of this analysis, did you look at immunization rates in these states, or do you have any intention of doing any comparison with immunization data for hepatitis B?
That has not come up yet, but I think it is a good point, and we may see perhaps states with higher immunization rates with, lower mortality in the long run, especially with universal Hep B vaccination in place. So it's sort of like kind of thinking through what type of data sets we can look at that has that information at the jurisdictional level would be sort of in the planning phase for that.
Thank you. That's really helpful and I think very interesting. Though I would also question the completeness of immunization data, especially for adults, if that's a challenge, or it's likely to be a challenge. So I think just thinking about action items for jurisdictions, we only have a couple minutes left, but if anybody has any recommendations on approaching using mortality data, using it as a metric to or how to use it as a metric when measuring progress towards elimination.
Yeah, I can start. I guess it sort of depends on where a jurisdiction is at with their elimination work, and also where they're at with their surveillance activities. And if they have well-established surveillance, they could certainly pull in their vital records data from their vital records office, establishing a data use or data sharing agreement to pull those in and match those data so that you have like line level data together with your surveillance data. For jurisdictions that are sort of like in a more early phase, I think of like the work that Hawaii did with just doing, quick analyses with CDC Wonder just to establish baseline mortality estimates so that they are able to indicate and have discussions with leadership on, what the mortality burden looks like in their jurisdiction. And just to mention that, though there is bias and we know that underreporting is a big and well-documented issue, if they look at the analyses over time, those biases should be, constant. So looking at trends is still informative.
With probably 30 seconds. Oh, nope, 0 seconds left. Well, that's really helpful, Kathleen, and thank you. I think, Zakia, do you want to close us out or?
Yes, I can. Hi, thank you all so much for all of this information. It's definitely bursting through my mind, and I'm pretty sure everyone else in the group agrees. I do want to say thanks again, and we will be meeting again next week on April 26th to talk with NVHR and the Center for Health and Law and Policy Innovation about Medicaid access. So hopefully we will see you all next week and have a great one. Thank you so much.